Hey, my name is Ben Anayati, and my research question is, do adults who have had a stroke show improvements in ADL performance with an intervention of electrical stimulation? So my findings were limited to focus strictly on the upper extremities rather than lower extremities because I focused on OT interventions. There were generally more strengths and limitations in my studies, and the authors have cited several resources to support their methods. With this, electrical stimulation may show improvements in ADL performance in individuals who have had a stroke, but more research is required to fully support this. So in my first article, it was a level 2 evidence, and it was a pre-test post-test control group designed randomized control trial. There were 362 subjects who first experienced a stroke within the past 4 weeks that didn't lead to any motor deficits, and they were aged between 50 to 85 years old, and they were able to reach and manipulate objects independently prior to their stroke. The intervention investigated was that there were 16 subjects that received both the usual arm therapy and EMG-triggered electrical stimulation. The eStim was applied to each of the muscles for 30 trials for 15 minutes, and it was given 5 times per week for 4 weeks. The eStim was applied to the thumb abductors, wrist extensors, elbow extensors, and shoulder flexors. The comparison group was 17 subjects in the control group, and they received the usual therapy for 3 hours per week in group therapy and 1 to 2 hours per week of individual therapy. The outcome measures used were the manual muscle test, the motor assessment scale, and the feasibility of EMG-triggered electrical stimulation. Unfortunately, there were no statistically significance between the groups. And the limitations of this study was that there was no effect size mentioned and the ethnicity of the subjects were not reported. As for the second article, which was also a level 2 study and a pre-test post-test control group designed randomized control trial, there were 67 subjects whose it was their first time experiencing a stroke, and they had a max of 2 days post-stroke. They had full range of shoulder motion with an increase in tone in muscle surrounding the shoulder, and they had less than 9.5 millimeters of degree of subluxation. So there were 24 subjects that received both the bow bath technique and eStim, and the subjects that received the eStim, it was for every day, twice a day, for 10 minutes, and the bow bath techniques were administered every day throughout the week. As for the comparison group, 24 subjects received the bow bath techniques every day during the week except for the weekend, and this was the control group, and there was no placebo group where eStim was administered. And for this one, the outcome measures were the changes in the X-ray findings by radiological measurements and the motor assessment scale. So the shoulder joint displacement of the X-ray values were actually statistically significant in the control group rather than the treatment group, and this went for the horizontal, vertical, and total asymmetries as well as a vertical range. However, there was an increase and better findings in the motor assessment scale in the treatment group, which showed increase in motor recovery of the upper extremity function. However, the limitations of this study was that there was no power analysis, the primary researcher was not blind, there was no effect size, training of the therapist was not delivered, ethnicity of the subjects was not reported, and the study could not be designed as a follow-up study. As for the last study, it was also a level 2 study, and it was a pre-test, post-test control group design, single-blind randomized control trial. And then here there were 38 subjects in the chronic phase, at least 6 months post-stroke causing hemiparesis. They had mild to moderate motor and/or sensory deficits in the upper extremity, and they scored within a 26 to 30 in the mini mental state exam, and their visual and vestibular functions were intact. So there were 17 subjects that received both the TENS unit and the task-related training for 30 minutes each, 60 minutes total per session. There were 5 sessions a week over 4 weeks, totaling 20 sessions. And the TENS unit was applied to the muscle belly of the triceps and wrist extensors at 2 to 3 times the sensory threshold. And so the same parameters were used for the comparison group, except the electrodes were not real electrodes, and it was a placebo. The outcome measures used were the Fugl-Meyer assessment, the manual function test, the box and block test, and the modified Ashworth scale. And all 4 of these assessments were statistically significantly higher in the treatment group rather than the control group. However, limitations in this study was that the ethnicity was not reported and the gender ratio between the groups were not equal. So basically the implications was that electrical stimulation with standard occupational therapy may increase one's individual upper extremity motor function in order to partake in their ADLs. This was seen with the application of the different forms of eStim, especially in the TENS unit. However, future studies are required with a larger sample size, longer treatment periods, a more diverse sample population with a report of the ethnicity, identifying which form of eStim works best, and identifying the optimal intensity of the stimulation units to further promote the positive application of these interventions.